Hello and welcome back to today's session. Today we are embarking on a full spectrum investigation into hemolytic anemia. This is the diagnosis of premature blood cell destruction. We'll break down everything from normal lifespan of RBC to the complex mechanisms of acquired diseases, all using our core analogy of the delivery truck fleet. Before we talk about destruction, let's understand the normal process. A healthy red cell delivery truck is built to last about 120 days. Scheduled retirement. After 120 days, the truck becomes worn out, its membrane loses elasticity, and its enzymes are depleted. It's time for the scheduled retirement. These old trucks are safely escorted to the main recycling depot, which is primarily the spleen and to a lesser extent the liver. This is a gentle, organized process where the components are recycled, iron is saved, and heme is converted to the bilirubin. Hemolytic anemia is simply the premature destruction of the RBC fleet, meaning the trucks are being scrapped long before their 120-day lifespan is up. The truck's body factory, that is the bone marrow, is working overtime, desperately trying to keep up. So here we have the R forensic clues, that is the laboratory markers. This destruction leaves clear forensic evidence. LDH and indirect bilirubin are elevated, so the waste from the massive rapid breakdown of the truck spills into the city's bloodstream, and hepatoglobin is decreased because the heme is going to bind to the hepatoglobins, and therefore free hepatoglobins will obviously decrease. The blood scavenger crew is overwhelmed and depleted trying to clean up the free hemoglobin. And reticulocytosis. The factory is working in overdrive, releasing immature trucks into the circulation to compensate. We classify hemolysis based on where the destruction occurs. So extravascular hemolysis, the depot destruction. The defective or the damaged trucks are removed from the circulation by the spleen and liver. The splenic maze is a harsh environment, and if a truck is rigid or misshapen, the spleen's macrophage inspectors grab it and dismantle it. This is the most common form. So it happens in spherocytes, like in hereditary spherocytosis. So these spherocytes are dismantled here. And intravascular hemolysis, it's the roadside explosion. The truck explodes while driving on the highway, spilling its cargo directly into the bloodstream. Oh, that's bloody. This is sudden and catastrophic. This is usually due to severe mechanical trauma or the complement cascade, which punches hole in the RBC membrane. Because hemoglobin is spilled directly into plasma, you can find hemoglobinuria or hemosideриnuria days later. These are intrinsic defects, problem built into the truck's original designs, passed down through genetics. So membrane defects, the truck's cases is fragile. Here we get hereditary spherocytosis. The case's components, pectin and chitin, are faulty, making the truck rigid and spherical, an easy target for the splenic depot. Enzyme defects, it's a vital engine part is missing, so G6PD deficiency. An enzyme protecting the truck from toxic fuel, that is the oxidative stress, is absent, leading to destruction when the truck encounters a trigger. And hemoglobinopathies. So the cargo container is structurally flawed. The container, so it's like it happens in sickle cell disease. The container deforms the truck into a rigid sickle cell shape under the stress, leading to blockages and destruction. In these cases, the trucks are born normal but destroyed by external forces. So we'll see these right now. These are the acquired conditions. So the immune mediated one. Autoimmune hemolytic anemia, the famous kind. The body security system attacks the fleet. So here we have types. The warm type, it's basically aggressive. It happens in IgG, and warm weather antibodies attack the trucks in the spleen extravascularly, leaving spherocytes. And the cold one, it's the IgM type. It's cold weather antibodies clump the truck in periphery, triggering the complement system to cause roadside explosions like the intravascular hemolysis. So here we do the Coombs test. It's basically the direct antiglobin test, and it acts like the police report, providing antibodies or complements are stuck to the damaged truck. So a positive result is the definitive sign of immune attack. So it will provide if the antibodies whether attached or detached to the RBC. If attached, then voila, it's a positive sign. And non-immune destruction, it's microangiopathic hemolytic anemia. The roadway is filled with razor wire strands, like the fibrin strands. Trucks passing through are sliced into fragments known as histiocytes. It's the pathologic sign of TTP-HUS or DIC. And mechanical trauma may be a damaged bridge like prosthetic heart wall physically crushes the trucks as they pass, and infections like the malarial parasite mycoplasma, they all invade and destroy the fleet. So hemolysis is a battle, not a factory error. By classifying the destruction site and analyzing the specific debris, the schistocytes, spherocytes, and the Coombs test, you would be systematically able to solve the mystery and treat the underlying cause. So this is how the analogy works. Now, when we dive deeper, so how do we approach this? So we have to ask 4 questions. Is there increased red cell breakdown? And what are the factors saying that there is an increased cell breakdown? That is, we'll have anemia with normal or elevated MCV, we'll have elevated unconjugated bilirubin from the heme breakdown, and we'll have excessive amount of urinary urobilinogen, and we'll have our serum LDH elevated as it's released from the red cells. And is there increased red cell production? If there is increased reticulocytosis, that is causing macrocytosis, that is causing increased MCV, and polychromasia, we'll have increased. So that signifies the elevated red cell production. And is there hemolysis? Is the hemolysis mainly extra or intravascular? So extravascular hemolysis may lead to splenic hypertrophy or splenomegaly. So the features and the intravascular hemolysis, so we'll have excessive plasma HB, we'll have methemalbuminemia, and plasma hepatoglobin will be decreased, and we'll have hemoglobinuria and hemosideruria, and so that's whole of it. And so for examination, we do jaundice, hepatosplenomegaly, gallstones, and leg ulcers. Leg ulcers, it's due to the poor blood flow, and gallstones, it's pigmented due to increased bilirubin from the hemolysis. For tests, we do FBZ, reticulocytes, bilirubin, LDH, hepatoglobin, urinary, so everything we saw. Thick and thin films for malaria screen if there is history of travel. The blood film may show polychromasia and macrocytosis due to reticulocytes, or point to the diagnosis, that is hypochromic microcytic anemia, sickle cells, schistocytes, and either abnormal cells in hematological malignancy, spherocytes, elliptocytes, Haynes bodies or bite cells, G6PD deficiency, that's due to G6PD deficiency, etc. So further tests, we do Coombs test to check whether there is complement or antibody coated red cells, or we do HP electrophoresis, we do osmotic fragility, and other enzyme assays as in G6PD deficiency. And the causes, we have 2 of them: immune mediated, direct, and the hereditary. So we have discussed these previously. For the immune mediated one, there are types: drug induced, drugs like penicillin or quinine, they induce it. And autoimmune hemolysis, so we have saw there are 2 types. So the cold one occurs in the cold temperature, and the warm one occurs in the body temperature. And the cold one may follow the infection of mycoplasma, and so that's most of it. And that's it. And we check for pyruvate kinase deficiency too. So that is it on a general overview of hemolytic anemia. Now let's dive into autoimmune hemolytic anemia further on the next session. Until then, keep revising.